This is a great conference. As an interventional cardiologist, it's definitely exciting, but this is kind of how I feel. Hopefully we can talk a little bit about, we're expanding field of left atrial appendage closure, and everyone has a different way of doing it. As an interventional cardiologist, I hope to share some of the pathways we've developed and things we've done to help not only get patients in, get them safely through the procedure, and then have great follow-up. So again, talking about optimizing workflows, pre-procedure, procedure, and post-procedure. Now, do we even need to do this? Because if we're operating under efficiencies, what makes things efficient? We want to have the device put in easily and quickly. And we've got data suggesting that sometimes there's 99% implant success. Now, but is implant success a real component of efficiency, or are other things more important? I would argue that not only is time of implant important, but death is a major inefficiency, and use of DOACs are a major inefficiency, right? DOACs require insurance pre-authorization, if they're on Coumadin INR checks, and so we know 20% of our patients don't even take DOACs who are prescribed. So based on the Amulet IDE data, there is a role with this particular device to improve efficiencies in terms of death and in DOAC. Now, is there a role for any other device? Am I just wasting your time? If we look at some of the data that's been published, across study after study, we're looking at almost 98% implant success. So what is the role for Amulet? Many of you in the audience know it's dual seal closure. Why is this important? Because we know that not every appendage can be closed or approached the same way. Having dual option, the dual mechanism of closure allows treatment of a wide variety of different devices, the lobe and the disc. Now, the beauty of the disc, especially from an interventional perspective, dealing with ASDs, PFOs, VSDs, paravalvular leaks, on-label and off-label, is a lot of the sealing happens with the disc. The lobe is a 2 to 3 dimensional object, and I would say a 4-dimensional structure, because the left atrial appendage not only has size, depth, and height, but it changes over time. So the disc gives you added security for completely closing off the appendage. Again, there is a wide variety of devices that can be used. Again, improving inefficiencies. One of the worst things we worry about is working on a patient, bringing them into the lab, and then not being able to close the appendage. That's the ultimate inefficiency. And so this device allows for greater treatment of a variety of different patients. Some of the differences between the Watchman and the Amulet. Now, the device size of the Watchman Flex does have a larger device, but one of the most critical things are the chicken wing appendages, anterior chicken wing, ones that are shallow depth, and appendages that have attempted to be closed by surgeons that have not been closed. So very, very small appendages, variable necks. So if we look at, this is from the Pinnacle Flex trial, complete seal in this large study was about 88%. So again, as we're starting getting to the details, not every appendage can be effectively closed by a singular device. Also of note, and I bring this up, is it's not just the Amulet IDE trial, but we also see this in SURPASS and also in this Pinnacle trial. Mortality is getting close to 7 to 8% at 1 year. So what we don't know is what we don't know. We have this notion of acceptable leaks. Are these acceptable leaks unacceptable to the survival of the patient? Is DRT more of a concern than we're actually giving it credit to? And what do we do about 1 year mortality in an elective patient? So pre-procedure efficiencies we rely on, number one is our heart-brain clinic. Our heart-brain clinic helps us to see patients effectively with a neurologist. And this is tremendously effective because not only do we see AFib patients, we also see cryptogenic stroke patients. And they're evaluated immediately by a neurologist. Patients love it. For our Amulet patients, these patients now all of a sudden have their non-participating physician note in there. They don't have to go to their private practice doc. You don't have to chase down another physician for the note. It all gets done. And so we have clear delineation of roles. Our administrator uploads any films. Our nurse navigator coordinates the visits and any additional testing. And then we have our APN who sees the patient in clinic, in hospital, and then post. And then the heart-brain clinic allows us to stream all of this. And so the success of this is we've gone from a heart-brain clinic of once a month to a heart-brain clinic twice a month. And we're going to almost weekly so we can get more and more patients through. Now, yes, there are some inefficiencies here. There may be someone with AFib, but the beauty of it now is we're trying to incorporate our EP docs in because we're seeing AFib that can also be treated with catheter approach. So this is a nice way we bring it in. As part of the pre-procedure workup, one of the inefficiencies we always worry about is we bring a patient into the lab and the appendage is not favorable to closure. Having a CT scan prior to bringing the patient into the lab is tremendously helpful for us. A lot of these patients have CTs from their TAVRs or from their mitral work, and having a CT scan allows us to effectively assess the appendage before bringing them to the lab. Therefore, we can make decisions on where to do the transseptal. We can make decisions on what type of sheath we need to use. And here's just an example of some of the workups that our Abbott team in Chicago have put up together that allows us to really assess the appendage, assess where we need to do a transseptal, so we're not wasting too much time. So one of the big things that's going to improve efficiency is Amulet with ice. Now, we love ice. Amulet is very easy to see on ice. We don't have to worry about compression. We do have to worry about compression. We don't have to have exact objective assessments of compression. But I think Amulet with ice, anesthesia, DOACs, TE, I apologize. They may go the way of these guys. Because what are some procedural efficiencies? The cath lab, we can do with, if you're doing left atrial appendage closure in the cath lab or the EP suite, you don't need the operating room. Our operating room charges $65 a minute. Anesthesia controls the operating room. There's a huge slowdown. We use conscious sedation, not general anesthesia. There's no tube going down. There's no general anesthesia. There's no chipped tooth or sore throat. Intracardiac echo, not TE. We're not requiring someone else to use their time to be in there. We'll use vascular closure devices, not manual pressure. Vascular closure devices also improve our efficiency with ultrasound access. Bilateral femoral venous access facilitates control of ice. We do our transseptal with VersaCross and device prep. So here's some of our procedural things. We love our anesthesiologists, but sometimes their motivations aren't the same as our motivations. We want to, as EP docs, you've got another ablation you got to do, another extraction. I've got other cases to do. This allows for faster turnover if we don't need anesthesia. And we know that using Perclose and ProGlide as vascular closure allows for faster turnover, increased safety, and improve optimization. So pre-closing these vessels becomes really, really important and helps improve flow through. This particular case, again, this is looking at Watchman data, looking at conscious sedation versus general anesthesia. Conscious sedation with Versed and fentanyl, safe, patients aren't doing worse. Because what's the fear? You're using conscious sedation, bad things happen, and you have to convert to general. It doesn't happen. It's easy to do and easy to control. This is a picture of our vascular access. Now, I work in the south side of Chicago, a very economically disadvantaged area. Also, we have long winters in Chicago. People put on little extra layers. So groin access is a little challenging sometimes. And many of us have struggled when we do a transseptal going through a groin that is unfavorable or has been accessed before. Sometimes just degrees of anti-clock at the groin don't convert to degrees of anti-clock on the septum. So I will always use a sheath and sheath technique. I'll put my ice on the left side in a 10x40 sheath so the ice catheter can get into the IVC. And then on the right, I'll do my transseptal either through a 16 or 18 gore. I'll use a 16 gore if I'm going to use a 12 torque view. I'll use an 18 gore if I'm going to use a 14 torque view. So 2 groins. I also like separate groins. I know different people will say, well, 1 groin, 1 big hematoma, 2 groins, 2 hematomas. It's easier for one operator to control this. Transseptal hygiene becomes absolutely critical for efficiencies. A bad transseptal can extend the case. A bad transseptal can lead to huge complications. And so using intracardiac echo becomes incredibly, incredibly effective in terms of seeing where we need to go. In this particular case, we're seeing in a cartoon of what the 3D ice looks like with Phillips, where we need to go. We can assess the left atrial appendage. This allows easy clearing of the left atrial appendage to make sure there's no clot, make sure there's no effusion. I'll use the VersaCross. One of my colleagues is here in the audience. We go back about 200 years. We all grew up learning to do transseptals with SL1s and BRKs. But why? This is better. This allows for easy placement, easy crossing, and a wire that's stiff enough to allow not only the torque views to get across the sheets, but it's stiff enough for my MitraClip sheath to get across as well. So another efficiency is not having to switch out a wire. So here's an example of transseptal access. Always use the sheath to dilate the septum. Now, perhaps the trickiest part is with the 4D ice to get the ice catheter into the left atrium. Because while you can have good images from the right atrium, you want to be able to have great images from the left to make sure you have a good implant. So how do you get the ice into the left atrium? You know, you can play dice. You can do a double transeptal. You can try to hope that the ice will get through. You can follow the wire across. Well, I'm an interventionalist at an EP conference. I use a balloon, and I do a septostomy, which makes life a lot easier. So there's an example of my balloon across. I use a 12 by 40 peripheral balloon, and the ice catheter slides right across. Makes it really easy. And there's a lot of great data also suggesting that, I try to tell myself, well, I'm doing a little left atrial shunting. This is going to help their HFpEF. Things we tell ourselves at night to get a good night's rest. But it does pretty well. TE gets some really great measurements, but all of these measurements can be obtained with ice. And so a cornerstone of improving efficiency is going to be ice. And that circumflex becomes absolutely critical to amulet deployment. We want the lobe to be 2/3 passed. And on ice, this is images we can see really quickly. Now, the views are a little different with the ice catheter. And again, this is, I guess it was supposed to play, but we can see images from our VeriSight of what is normally would be a 45, 135, or 090. We can get very easily with the ice catheter. And so imaging the left atrium once our sheath is across, not only can we get X-plane views, 45 and 135, can also get 3D views. And the 3D views become absolutely critical because then all of us are concerned, what about that big disc interfering with the pulmonary vein, interfering with the posterior leaflet of the mitral valve? We can see it under 3D, and so not only can we get optimal measurements of the appendage, we can also assess for adequate closure. Now we're at the device. Here it comes out of the plastic. Some of the things I like to do is I like taking the non-rotating stopcock off, putting 12-inch connection tubing, and then a stopcock on, so my fingers aren't interfering with the 2E valve. Another potential option for improving efficiencies is the transeptal. So that it's oftentimes we get into the left atrium, sometimes we have to anti-clock and clock. The transeptal sheath makes it a lot easier. Once you're in the left atrium, you can easily get into the appendage and deliver any variety of size of device. With the 12 and 14, this is what the sheath looks like. Here's an example of how we prep it. We go ahead and hook it up to a pressure bag, open up the pressure bag, tie it up, and we use a modified MitraClip prep. So rather than using syringes or pulling back, I'm just using a flush, and I'm just smushing and pushing, smushing and pushing. This gets the air out. We'll hold it up to the air, we'll nick it, and that's with a constant flush. We're not having to refill our syringes. Saves time. Then we go ahead and we'll hook it up directly to our, our flush bag. We'll screw it on as it's going. And then the process of the procedure can be broken down into the 3 different aspects: ball, lobe, disc. So efficiencies is how to hold the cannula. This is all the sheath. This is all one hand. So what I try to teach my fellows for efficiency, one hand on the groin, because that's the best way to torque the catheter. So we're going to unsheath to ball, and then advancing to lobe with my left hand on the groin, anti-clocking or clocking or holding pressure, and a kind of different way of holding the cable underhand allows for better control. The other way to hold it underhand, we always hold things overhand because we have greater arc of motion and greater control. Underhand is a little less, but this allows for slower deployment and more accurate deployment. And then finally, unsheathing to disc, and then our final shot. The close criteria, we want to make, this is where ice becomes very helpful. 2/3 past the circ, lobe compression. We want to have orientation of the lobe and axis with the LAA neck, separation, and elliptical. All of these can be seen with ice very, very easily, negating the need for TE. And our final images are fantastic. Here's 135 with the tension test. In non-Boston locations, I call this a deflated Tom Brady football. I guess now that he's out, we can't really use that term, but that's what it should look like. We can see flow. And the only data we have right now in looking at ice versus TE, a large study looking at primarily with Watchman, successive implant, no difference, less use of general anesthesia. Again, a key facet to improving efficiency, but no difference in all-cause death or composite major adverse events. There was a slight increase in pericardial effusions. Again, my thought is that this is not just 3D or 4D ice. This study was also done just with 2D. So with 3D and 4D ice, it may be help because someone is always watching. And after the procedure, we've got to watch our patients. So standard order sets for every single one of these patients, including the very famous term, this patient has made a remarkable recovery and is be allowed to be sent home the same day, so patients can go the same day. When they leave, we get a cardiac rehab. We schedule them with a 45-day visit with their TTE. The reason we do that is I don't like getting another TE if we don't have to. CTs at 45 days are too early for the device to endothelize, but we have to get an echo for the registry. So that happens at 45 days. At 6 months and at 12 months, we'll get a CT. The APN sees the patient in post-procedure clinic, and pre-printer letter, email, and the Epic in-basket automatically goes to the referring physician. And so same-day discharge with Watchman we know is effective. We know patients can go home the same day. Patients are really happy, and hospitals love it, having the extra bed. One of the huge efficiencies with the Amulet compared to Watchman is if you have successful closure and you have no leak, higher degrees of patients are now going home on off of DOACs and NOACs and going home on oral antiplatelets. So here, looking at whether it's early experience, moderate experience, or high experience implanters, the vast majority of patients go home on DAPT and not on DOAC. Here's just another example of closure with ICE. So in conclusion, I look at it in terms of improving efficiencies in 3 arenas. The pre-procedural arena, identifying the patients, having a working heart-brain clinic, getting a CT scan on all patients, knowing what you're going into. In terms of the procedural, key components, conscious sedation, intracardiac echo, you doing cases in the cath and EP lab, using a VersaCross, a steerable sheath, using pre-close, ProGlide for the sheaths, and post-procedural, same-day discharge, being able to use dual antiplatelet therapy. The MAPT is my own version. It's not FDA approved, not indicated, but there are some patients who we do MAPT and we have good data on, and getting a CT scan and same-day discharge. And so with that, I want to thank you for your time and your attention, and I'm happy to answer any questions you may have.
Thank you so much, Dr. Shah. I'd love to, as he said, let's open it up for questions. Anybody have a question for Dr. Shah? Yeah, Maddie.
I'm Maddie. I do work for Abbott, so this is just a question from our side. I've been starting to do ICE here with Dr. Kapoor at Brigham and Women's, and he's excellent at ICE. But my only question for you is, what is your workflow for saving the images? Is it your Abbott rep that's saving the images for you, or is it someone on your team?
That's a great question. So it's something that we struggled with. So when we're using the Philips 4D VeriSight, so when we had the Zonair system, the 2D, it was usually my staff who did it because there was not too many buttons and things to do, and oftentimes the Abbott representative couldn't maneuver it. With the Philips VeriSight system, it's much more complex. And I didn't go into all the details, and I'm not sure what Dr. Gafour is saying, but once our catheter's in the left atrium, you can auto steer in the left atrium, you can go 45, 135, you can go to 3D. And that was beyond the scope of what our techs could do. So what we asked Philips to do was to train our techs. And so we asked them to take them to sessions. We asked them to be there for every case. And I would always pull one tech in. We created one tech to be a super user. And so then he can now teach the other techs. And so we've created an ICE curriculum for them as well. So now that if the Philips rep isn't there, and about 30% of our time our Philips rep isn't there, our techs will go ahead and run it. Now we are also spoiled because in Chicago, one of our Abbott clinicals was a former ICE rep. And our ICE program at University of Chicago would not exist without her because she's been really able to fill in and help the techs as well. So there is a learning curve, but then we try to simplify it. I've got a card for my techs, what to look on, how to turn the machine on, what to connect, what buttons to press, what views we should get, and that's how we acquire it. Let's try to really simplify it.
Wonderful. Thank you. Any other questions?
Dr. Shah, I was pleased to see that you've already started making kind of your own decisions about what anticoagulation is going to go with which patients. Would you mind just sharing a little bit about how you decide that? Like what factors you look at and think about?
Yeah, thanks, Dr. Daughter. So right off the bat, the default is aspirin and Plavix, loading the patients 325 and 600, and I actually will load them before the case. So they're loaded beforehand. During the procedure, if everything goes great, I'll continue the DAPT for full 45 days. Now, if something is off, if let's say their Has-Blood score is 7, or they come in and they've had a recent GI bleed, or they're coming in and just recently they've had severe epistaxis, or they're within the first 3 months of hemorrhagic stroke, in those cases, I will then default to clopidogrel monotherapy. for 45 days. But I'll still load everyone on the aspirin and Plavix, so at least they have it on board for the implant. And that's kind of what we do for our PFOs, our VSDs, our ASDs, our TAVRs, and our Eclipse. So we just put that in our order set for any of the structural cases, so they're loaded. And then there are some patients who have a clopidogrel allergy or patients who are clopidogrel non-responders, in which case, again, off-label, I will use ticagrelor. There are some patients I have used prasugrel, provided they haven't had a stroke, either in the situation of DAPT or MAPT.
Wonderful. Any other questions? Okay, well, let's give another round of applause for Dr. Shah. Thank you so much, everybody.